I'll be introducing our first speaker. Reproducible and consistent post-operative results are crucial. This starts with a complete pre-op workup. Our first speaker, Dr. Vaishnavi, is a young and energetic cataract surgeon from the Eye Foundation, Coimbatore. She completed MS Ophthalmology from Arvind Eye Hospital, Madurai, and her area of expertise is glaucoma, pediatric, and neuro-ophthalmology. She'll be talking on pre-op workup routine to deliver 20 by happy outcomes in the post-op period. Over to you, Vaishnavi.
Thank you, Tamarsi. A very good evening to everybody. So the next couple of minutes, I'll be taking you to various preoperative evaluations and investigations routinely done in a hospital before a patient is posted for cataract surgery. Preoperative evaluation of cataract begins with a good history taking. History of tamsulosin should be elicited in elderly male patient. Knowing that the patient is on alpha blockers, which can cause IFIS, different modifications and techniques can help in achieving excellent results. Aspirin and warfarin can safely be continued, and the risk of hemorrhage is less if the international normalized ratio is in the therapeutic range. Routine screening of HIV, HBsAg is also done, as surgeons and paramedics are at increased risk of exposure both in OPD and in OT. Congenital swab syringing is also done in 1/8 patients. Blood sugar and ECG is also done in all patients. Antibiotic prophylaxis is a common preventive measure. As such, there is no universal guideline. There is a wide variation in antibiotic agent used, administration, timing, and the routes. The evidence supporting it is not very compelling, leading some surgeons to forego it completely. But even prolonged use can cause resistance. The vast majority of the respondents in 2014 ASCRS, 90% have used topical perioperative antibiotics, and almost 97% of the surgeons have used it post-operatively. Here in our hospital, we use the 4th-generation fluoroquinolones 3 days prior, 4 times a day, and which is continued 1 week post-operatively. So some patients who have not had a dry preoperatively or were not picked up earlier, or if preoperative evaluation is not accurate, we may have poor surgical outcome and unhappy patients. A person who is educated properly about dry eyes is more likely to adhere to recommended treatment regime. Sometimes dry eyes can make your biometry measurements very inaccurate. If there is a lot of variability in your measurements as this in this slide, it's better to put your patients on medications, tune up the corneal surface before you take the final measurements prior to cataract surgery. Once you treat the dry eyes and stabilize it as evidence from these measurements, you can confidently go ahead with phacoemulsification. And proper examination of the slit lamp is mandatory. The most important are the fluorescence staining and blink rate. The other test can also supplement our evaluation. So evaluation of the ocular surface is very mandatory. According to phaco study results, which showed that 63% had a tear breakup time of 5 seconds or less, 22% of these patients carried an established diagnosis of dry eye, and of these, 77% of the patients scheduled for surgery had corneal staining. So, briefly delaying surgery until the ocular surface is stabilized is mandatory. So, we all know that MGD is an important cause of evaporative dry eye. We perform lipview, which combines mammography and lipid layer thickness. It also analyzes the architecture of the gland and dropout areas. If less than 1/3 glands are truncated or small, it indicates mild MGD. If greater than 2/3 are truncated, go ahead and treat the MGD first and then proceed with phaco. It also helps us to plan operative technique and the use of liberal viscoelastics. So specular microscopy determines the outcomes of corneal effects of surgical procedures. Ideally, around 2000 to 2000 cells are safe for any anterior segment phacoemulsification, but less than 1000 carries the risk of post-operative corneal decompensation. So all patients here undergo specular microscopy so that if there is any underlying dystrophy, we can take extra care during phacoemulsification and also apprise the patient of the need for future corneal surgery. Then biometry is done. Then the patients are counseled according to the biometric readings. Of the whole lot of optical biometers, we use IOL Master 700 and incorporate Barrett's TK formula, which take into account the corneal thickness, anterior curvature of the cornea, and the posterior curvature of the cornea. We have Barrett TK Universal 2 for non-toric, Barrett Universal TK Toric for toric lenses, and Barrett True Take for post-LASIK. Always check both the eyes, and it has got a swept source OCT so that it can penetrate into denser cataract. It has also got a telecentric keratometry, so the accurate K readings are obtained regardless of the pupil size. Actually speaking, we are not aiming for emetropia, but just ensure that at least 95% of the patients end up in less than 0.5 diopters of residual spherical equivalent. But not all can afford optical biometry. In case of very dense cataract or people involving corneal opacity, a well-done immersion gives equal post-operative outcome as that of an optical. And this is a very well-done immersion biometry with equal spikes. And we incorporated Barrett's formula into the immersion. And then we went ahead and did a toric IOL. So we do topography. The main thing is that it highlights the corneal pathology and detects irregular astigmatism. And in case of post-C3 patients undergoing cataract surgery, and even for toric IOL, topography plays a major role. And we use the aberrometry by Hoya. The main use of this aberrometry is is used to check the source and the amount of aberration and to check for ocular alignment. Here, this is the internal aberrometry. This is the aberrometry due to cornea, and this is aberrometry due to the total reflection. As we can see in this slide, most of the aberrations are due to the internal. So we can safely go ahead and implant a multifocal IOL. And always check for the optical alignment. If the angle alpha is more than 0.5 to 0.7, the optical axis or the center of the capsular bag will not match the patient's visual axis. So this can lead to potentially unpleasant refractive surprises if a multifocal IOL is implanted. Some patients forget to tell about the refractive surgery done a couple of years back. This patient was planned for elective cataract surgery, but you see a closer look revealed a flat K in the right eye. When further asked, the patient gave history of a LASIK surgery done in the right eye 30 years back. Then the mode and the formula is then changed for the LVC correction in the right eye, and the IOL power is calculated. And OCT is done in almost all the patients, and particularly in patients who are planned for toric or premium IOL. This patient had a nuclear sclerosis of grade 2 in both his eyes, and OCT revealed a thick epiretinal membrane in his left eye. And then the surgery was planned as phacoemulsification with vitrectomy. Post-operatively, he was left with the residual power of -0.5 with best corrected visual acuity of 6/6. So perfect evaluation will lead to happy patients. Always validate the measurements and spend more chat time with the patients, especially patients of multifocal and toric intraocular lens, and always stay informed about the latest developments. Thank you.
Thank you so much, Vaishnavi. That was a very nice, elaborate presentation.
Thank you,
sir. A nice introduction to the whole webinar. One of the things we have started doing in our center is that, even before we do the counseling, we always do a biometry. And where in centers where we have an optical biometry, like the IOL Master 700, like Vaishnavi said, we go through it, and then because we want the entire counseling for the patient, whether the patient goes for a toric or not, even if opts for a multiple, is decided based on that. And even if centers where we are doing immersion A scan, we do a manual keratometry and then go ahead with the counseling. This is a change we have introduced almost a year back, and we find that it works well for us. Any comments from the panelists?
Can I talk, Ramu?
Yes, Mohan, please go ahead.
I think it is a brilliant talk by Vaishnavi. Chennai's loss is Coimbator's gain.
Thank you, sir.
Working with me, and she did so very well. And the parameters, what I normally look at is about 5 parameters preoperatively. One is the status of the ocular surface. You mentioned that as well. Second is the corneal endothelium. That also you mentioned. The pupillary dilatation preoperatively, I want to know exactly. And the density of the cataract, and of course the status of the macula. I do OCT for all the patients. I think all these things you have covered very, very, very nicely. And I think these are the key take-home points. One important thing is, as soon as a patient walks into your clinic, because they all come with the diagnosis, they all come with the cataract diagnosis. The diagnosis is not a major issue. So as soon as they come in, we do the biometry for them. We don't even do the non-contact tonometry for them, because non-contact tonometry can also alter the ocular surface and alter the K values as well. So this is one important thing you should all understand. Once they check the vision, straight away go in for the IOL calculation, whichever, whether you have got IOL 500 or 700 or IOL master lens star or whatever it is. Or nowadays we are not doing immersion scan or even contact exam for the post-COVID era. Yeah, we are doing only the optical biometry now.
Any comments, Amaipal?
Yeah, so Ram, what you said is absolutely right. So on that particular day, the most important thing is actually the keratometry. The IOL, if you have to do the A scan, that can be done later. That doesn't matter. And even the biometry in the IOL master, if you're looking at the A scan, the axial length, there won't be much of a difference if you have touched the cornea or not. But the basic thing that you need to do is the keratometry. So that needs to be done before you do anything else. And I think that's a very important thing that has come, because if you look at the readings do change significantly. And at times a patient who may or may not require a toric, you may do the flip side, that the astigmatism comes out much higher than what is supposed to be, or vice versa. So I think it is very, very important for you to be working on a virgin cornea at that particular time, untouched cornea at that time, especially for the keratometry.
Absolutely valid. No, actually, we have also started using almost exclusively Barrett suite of formulae for all our cases. We have 10 different centers. In some centers, we don't have the optical biometry. Even there, even if you use the immersion A scan and manual keratometer, we go to the ACRS, APACRS websites and take the benefit of that, whether it's toric or just simple spherical lenses or post-refractive surgery, etc. Uday, can you highlight on this concept and what's your go-to formula?
I'm one step beyond. We're using artificial intelligence. It's at iolcalc.com. So Barrett's a great formula as well, but I think we have gone beyond that. So we're doing the Lattice 2.0 with artificial intelligence. So we have a continually evolving formula. So it's not static, it keeps evolving.
Mm-hmm.
In our center, if we promise you a Plano outcome and you're not there, we will do the LASIK for free. So we have a very strong incentive to be as perfect as possible.
We don't promise them, but we anyway do it if the results are not appropriate.
Absolutely.
Yes, Partha, good that you joined me.
Thank you very much, sir. Thanks a lot for having me in this platform. Vaishnavi, very nice talk. And I think you covered the more important part and stressed on the importance of these very important parts as it stands today. So one thing that I would like to know from Sir and Vaishnavi both is along with the other investigations which we do routinely along with the OCT, which are the patients whom you would like to do an eye trace? Would you like to do an eye trace for every patient and the topography for every patient? Or would you select these two from the rest of the patients, rest of your cataract patients?
To be frank, our routine cataract patients who receive spherical intraocular lenses, none of the mill cases, we don't do a topography or a eye trace. It's basically, our management is not going to change in any way. It's only those who are going in for toric intraocular lenses or multifocal intraocular lenses where we do both these tests. Basically, in toric intraocular lenses, we want to make sure that the corneal astigmatism is quite regular. We are not having a keratoconus or inappropriate cornea. And also, we want to make sure that the corneal surface is pristine for getting a absolutely correct refractive measurement. The IOL power measurement. And as far as multifocal intraocular lenses, apart from the factors I mentioned, we also look carefully at the angle alpha. And it is generally said beyond 0.5 millimeters, you be careful. So in my experience, I find that there are quite a few patients who fall beyond that, and our own number is 0.7 millimeters. Beyond that, and if it's a lot of higher order aberrations on the anterior corneal surface, a lot of coma, trefoil, then we stay away from multifocal intraocular lenses.
Okay.
The angle alpha is a little more, then you can go in for a lens which has got a little more diameter, the central ring like symphony. So I've done it for even for 0.8, 0.9 also, the symphony works wonderfully well. if you're going to choose a multifocal in these patients. The patient is motivated enough to do the multifocal, then a Symphony is probably the lens of choice in these cases.
Yes, Arup.
Yeah, so there are 2 points I would like to make. Vaishnavi, as it was a wonderful presentation. Number one is for the premium intraocular lenses, the lifestyle lenses, I do multiple readings. Now, I will not be satisfied with just one set of biometric readings. So there has to be 2 or 3, and I need to get a concordance between 2 consecutive readings. And second thing is my go-to formula would be a Barrett-Toric calculator. Last couple of years, I think 4 years or so, I've been using only the Barrett-Toric calculator, not the Barrett Universal 2, because Barrett-Toric has the Universal 2 incorporated within it. And so I think these are the 2 additional points I thought I would like to make.
Thank you. Any comments, Chitra?
Yeah, can I add something?
Yeah, please, Rohit.
Yeah, in patients wherein, we have so many intumescent cataracts nowadays. So in intumescent for all practical purposes, I'm using the Barrett formula. That goes without saying, because that probably is the best as it is evidence-based. For patients wherein the lens thickness is more than 4.5 or 5, we take into consideration Hoffer's also, because Hoffer's results are as good as Barrett's when it comes to lens thickness, more than 4.8 or 5. Because we find that in our cases, we are ending up with slight hypermetropias. With Hoffer's, we have we take a combination of both Hoffer's and Barrett's when it comes to patients with intumescent cataracts with lens thickness more.
Thank you.
But the Hoffer formula doesn't include lens thickness in the calculation.
Yeah.
It includes.
No, it doesn't.
Hoffer doesn't include.
Hoffer doesn't.
Hoffer only includes the K value and the axial length.
Axial length.
Yeah, but then it has been seen that with the lens thickness more than 4.8 or 5, Hoffer's works as good. So by the time I show I'll give you the reference now.
I think it's controversial. That's one of the reasons why we are given up using multiple formulae, because if they give multiple different powers, you are left with the which one to choose. Somehow we have recently shifted over to the Barrett group of formulae right through, and at least in our hands, most often it's working well, not that we don't have refractive surprises at all. Any final comments from Chitra and Shrish before we pass on?
Yeah. Very well, Vaishnavi. You covered everything and
Thank you, madam.
But something very basic more, because we would have an audience which would want to know that we shouldn't have missed ocular surface, which is very important, and especially the ocular surface is a little suspicious. Ensure that the lubrication goes on for a few months beyond the cataract surgery is again important. And the other very basic thing is the specular microscopy, which also should not get missed, because accordingly we could titrate our surgery as to how much, whether we use liberal viscoelastics or how you would advise your patient to be cautious that there might be a future corneal based procedure. So every single aspect of pre-op evaluation needs to be very meticulous.
Uday, can I ask you a question? Between the switching from the Barrett 2 to the artificial intelligence 2.0 formula that you're talking about, which is an evolving, in the clinical outcomes, has it made any difference between the touch-up LASIX as a percentage that you used to do vis-a-vis Barrett and now?
Yeah, so we looked through all the data, and with Barrett, we're somewhere in the mid 80%.
Okay.
Patients who are plus or minus a half diopter of target or a half diopter of plano.
Okay.
And with the lattice, I'm somewhere, depending on the specific set, but somewhere between 92 to 95% on target. Remember, the advantage here is that it's a self-learning formula, meaning that I can put in my own data and it can hone the calculations just for me, or it can do it for the whole library. If I have an unusual eye with an axial length of 30 millimeters, it can take the eyes from the whole library from surgeons across the world. We have 4,000 users now of IOLcalc.com. But at the end of the day, whatever makes you happy.
It's a huge jump from 80% to 92% is a significant jump, no? And is it commercially available or what?
We're in discussions with Zeiss, with Alcon to commercialize it.
Okay.
We are waiting till those talks kind of finish before we launch.
Okay.
We are overshooting time, but just to have the benefit of your opinion, Hill RBF also works on similar principles, artificial intelligence, data learning. How is LADAR a little different?
So the Hill formula doesn't have a backbone. In other words, it's pure AI, and that's why very frequently you'll see on your machine, you'll have an out of bounds calculation, and it doesn't know what to do with the calculation. That's what out of bounds means. With the lattice, we actually start with any formula. So you can start with the Barrett as your base formula, then apply our artificial intelligence to improve that. And the AI can only change the Iowa power by a half diopter one way or the other. So you'll never get a crazy surprise out of the AI. It'll never be off by many diopters. Whereas in Hill, because there's no starting backbone, you can have an out of bounds calculation. So the machine, if you look at your Iowa Master or your LensStar, it'll warn you, it'll say, warning, Hill RBF, this one's out of bounds. So with Lattice, you never have that. And you can start with any backbone. You can start with Barrett and now apply the AI to that. That's the beauty of it. And we call this plus. We can do Barrett plus. You can start with Holiday and then apply the AI. We call it Holiday plus. This is why it's so important to be able to keep evolving a formula, not be static. Remember, if you come up with an idea and say, you know what, we can now measure with our femtosecond laser the equatorial lens position, let me include that in the calculations. Well, Barrett has to come up with a whole new formula, not us. You can add it in there. We even made the trial, let's put shoe size into the calculation for the AI, give it the data, see if it does anything. And then 100 eyes, 200 eyes later, it kicks back that no, shoe size is irrelevant.
Okay. Thank you.